Good afternoon. I'm Susan Gross, and today we are going to be hearing the Population, Family, and Reproductive Health Master's Essay presentations. This is session 1 or group 1, and each presenter, I'll introduce you, and then we'll go ahead. You have 10 minutes. So let's start with Emily Lasher. Emily comes to us from Cornell University, where she received a Bachelor's of Science in Global and Public Health Sciences, and her concentration area was maternal, fetal, and perinatal health. And today her essay is on prenatal, melamine, aromatic, amine, and psychosocial stress exposures and their association with gestational diabetes, a San Francisco pregnancy cohort.
Great, thank you so much. Hi, everyone. I'm very excited to be kicking off this year's Master's Essay presentations. As Susan said, my name is Emily Lasher, and I'm just going to jump right in. So in the United States, 84,000 chemicals are registered for use. However, only a small fraction have actually been assessed for safety, and even fewer have been assessed during pregnancy. This is notable because pregnancy can heighten susceptibility to chemical stressors. Today, I'm going to be talking about two groups of chemicals. First, melamine is a chemical in plastics, fertilizers, and kitchenware, and is often accompanied by melamine derivatives such as cyanuric acid. People are exposed to melamine by ingesting contaminated food or inhaling house dust. In high doses, melamine can cause kidney failure, but it's also currently being assessed as a potential endocrine disruptor by the European Chemicals Agency. And in animal studies, even low doses have actually been associated with numerous health effects. Aromatic amines, on the other hand, are found in tobacco smoke, diesel exhaust, dyes, and more. People are exposed to aromatic amines through inhalation, ingestion, and dermal exposure through dyes and clothing. Studies on non-cancer health effects of aromatic amines are very limited. For both sets of chemicals, the biological half-life is short, ranging from minutes to days, and studies have found that most pregnant people actually have detectable levels of these chemicals in their body. However, very few studies have actually looked at the health effects of prenatal exposure. Gestational diabetes is a high blood sugar condition that can develop during pregnancy, which poses short and long-term risks to both the pregnant person and the child. The CDC estimates that between 2 to 10% of all pregnant women in the US are diagnosed with GDM each year. And due to rising rates of GDM, identifying modifiable risk factors is really important in preventing the condition. Previous studies have found that exposure to chemicals like PFAS and phthalates, as well as non-chemical psychosocial stressors, both can increase your risk of GDM. So the objectives of this study were to first evaluate relationships between exposure to these chemicals and gestational diabetes, and then also to look at if psychosocial stressors modify these relationships. So I conducted a cross-sectional analysis of data from the ECHO study, which is an NIH-funded national cohort study. English or Spanish-speaking pregnant women were enrolled early in their second trimester, and to be eligible, women had to be over the age of 18 and receiving prenatal care. Women with non-singleton pregnancies, fetal anomalies, and pregnancy complications were ineligible. Urine samples and questionnaire data were collected during the second trimester, and additional variables were also extracted from the medical record. The urine samples were analyzed in spring of 2023, and we analyzed 40 different analytes, including 36 aromatic amines, melamine, and then 3 melamine derivatives. Validated measures of perceived stress and depression were utilized as indicators of psychosocial stress response. Perceived stress was measured using the Perceived Stress Scale, or the PSS-4, and depression was measured using the Center for Epidemiologic Studies Depression Scale, or the CESD-10. To assess experience of discrimination among participants, people were asked, how often do you feel that you personally have been discriminated against because of your race, ethnicity, ancestry, religion, or color? Participants were asked to respond never, rarely, sometimes, often, or very often. And then analyses were conducted on complete cases. So I restricted the analysis just to chemicals with more than 65% of the sample above the limit of detection, and I used imputation methods to address values that were below the LOD, as well as specific gravity adjustment to account for differential dilution across urine samples. I also log transformed the chemical values. After calculating descriptive statistics, I created logistic regression models to look at associations between each exposure and GDM. And for the chemical models, beta coefficients and confidence intervals were actually multiplied by the interquartile range of the chemical in order to determine the odds ratio of GDM associated with each interquartile range increase in exposure level. I identified potential confounders prior to doing the analysis, which was informed by existing literature. And then lastly, I used interaction terms to test for effect modification. So 555 participants were included in the sample, and the average age at delivery was 33. The majority of the study sample identified as white or Hispanic and did not experience financial strain. The sample was also pretty highly educated. I categorized PSS-4 and CESD-10 scores, as well as discrimination responses, into 3 separate categories for analyses. And then 84 participants had a GDM diagnosis, which was 15% of the sample. So as you can see in the green box, melamine and cyanuric acid were detected in all of the participants, and amylide was detected in 99% of urine samples. Of the 36 aromatic amines that we tested for, 5 were detected in at least 65% of urine samples and were utilized in the analysis. Among all of the chemicals, the highest geometric mean was observed for cyanuric acid. So what did I find? The logistic regression models revealed increased odds of GDM for each interquartile range increase in levels of exposure to amylide and orthoanisodine, controlling for age, race, and SES. Specifically, exposure to orthoanisodine was associated with a 29% increase in the odds of GDM, though I do recognize that the confidence interval doesn't overlap 1. And then the odds ratios for all of the other chemicals and GDM were slightly less than 1. For the psychosocial stressors, compared to those with lower levels of perceived stress, participants with a PSS-4 score of 7 or higher had a 57% increase in the odds of GDM. And participants who stated that they experienced discrimination sometimes, often, or very often had increased odds of GDM compared to those that never experienced discrimination. And this was statistically significant, as you can see on the bottom. And then lastly, the interaction terms I created between the chemicals and the psychosocial stressors were not statistically significant. So this is the first kind of epi study to look at associations between melamine, aromatic amines, and GDM. I did find some weak positive associations between amylide and orthoanisodine and GDM. And I will say that weak associations are often expected in environmental epidemiology and doesn't necessarily mean that these relationships are not important. I would just call for kind of additional studies in other cohorts to really continue to evaluate these potential associations. The specific mechanisms behind the associations are kind of unclear. However, these chemicals have been found to increase oxidative stress and inflammation, which may contribute to GDM. I also did find evidence of discrimination increasing risk of GDM, which is consistent with the limited literature on this topic. It's been hypothesized that psychosocial stress leads to hyperactivity of the HPA axis, which increases production of cortisol and affects pancreatic cells, which could lead to insulin resistance. Alternatively, psychosocial stress, such as discrimination, may also just lead to like physical inactivity or unhealthy diet or obesity, which could increase blood lipid and glucose levels. So briefly, I just wanted to touch on the study's limitations. First, temporality. The exposure data was actually collected during the second trimester, which is also when GDM is typically diagnosed, which limits our ability to assess causality. Also, chemical exposure was assessed from a single urine sample. Ideally, you would have like repeated measurements. But I will say melamine levels have been shown to be fairly consistent over several weeks in other studies. For the purpose of this analysis, I excluded individuals with missing GDM data, which was about 100 people. But I'm planning to work with ECHO staff at UCSF on this prior to publishing. Also, you may have noticed the confidence intervals are pretty wide, which may reflect low statistical power. And then lastly, the study might not be generalizable to everyone in the US. The prevalence of GDM in the sample is higher than in the general population. However, the chemical levels that I found are actually fairly comparable to other biomonitoring studies that have been conducted. So to conclude, prenatal exposure to chemical stressors such as amylide and orthoanisodine and non-chemical stressors such as discrimination may be associated with GDM, but we really need future research to assess these relationships in other cohorts. I just want to thank Allison Gemmel as well as my colleagues at UCSF for their guidance and support, and I'm happy to take any questions.
Um, If there's any questions? Great presentation, Emily. I'm supposed to recognize, are there the students have any questions or you can put in the chat, I can read it or raise your hand. Okay, it looks like Allison has a question. Go ahead, Allison.
Yeah, I was like, if nobody else wants to ask the question, I have a question. So this has been great, and it was great working with you. I'm thinking about how highly educated and advantaged this cohort might be. How do you think your results might change if you were to have a different cohort that was more representative of the United States, or maybe even among lower educated people? Have you thought about that at all? I know we never talked about this, but I'm just wondering if you have any thoughts. Yeah.
I'm not sure. I think it's hard to know exactly how education is associated with the exposure to these chemicals because it's so ubiquitous. So I think like more like biomonitoring studies on these chemicals, I feel like is important. And they're currently not in NHANES, which really limits people's ability to know like how widespread they are. So I was really working with limited knowledge of kind of how much exposure is in the general population. I think like it could there could be a stronger association, but I'm not sure. And I think like looking at the interactions, especially in other populations, I think would be really interesting. And I think one method to do that would possibly be to kind of combine data from other ECHO cohorts as well. I know that a lot of the ECHO studies like use data from multiple cohorts. I was like limited in my time and resources. And logistically, I know that can be complicated, but I think that might, like the sample had like no non-Hispanic Black pregnant women. So like increasing the diversity of the sample could be important, and that could possibly be done through just using other ECHO cohorts.
David, do you have a question? You can go ahead and unmute, David.
I know time is at a premium, but I must say a great presentation, very interesting. Can you give us a sense, or me a sense of where you say it's ubiquitous, but are there more or less exposure possible to melamine and other of these environmental hazards, particularly during pregnancy?
Are you asking about kind of specific populations that are more exposed?
Where do you find these concentrations,
Mm.
and where are they greatest?
Yeah, I think what I had read was for melamine, a lot of it is through like plastics in foodware. And so people consume food that's contaminated with melamine. And I know previous studies, there was in 2008, I believe there was a few deaths actually in China from very high levels of exposure to melamine. And I think that triggered more research into the chemicals. And I think they actually found that the combination of melamine and cyanuric acid together was actually had like a synergistic relationship. And so exposure to both of those created higher risk of kidney like dysfunction. But I think, I mean, aromatic amines, diesel exhaust, tobacco smoke, so areas where maybe if you're living closer to a road, you might have greater inhalation. But I think, yeah, more studies on more exposure assessments, I think is important for these chemicals.
Thank you very much for a very fine presentation.
Thank you.
Okay, thank you so much. I have great questions for you that I'll ask at another time, but
Okay.
a really great presentation. Thank you, Emily.
Sounds good.
All right, so our next presenter is Xiaoyu Che. She comes to us from Peking University with a bachelor's degree in public health. She also was concentrating in the area of maternal, fetal, and perinatal health, and her essay title is Maternal Mediterranean-style diet adherence during pregnancy and metabolomic signature in postpartum plasma, findings from the Boston Birth Cohort.
Hi everyone. Thank you, Susan Girls, for the introduction. And hi everyone, my name is Xiaoyu. Today, I'm excited to share the findings of my master's essay, which investigated maternal Mediterranean-style diet adherence during pregnancy and postpartum metabolomic signature within the Boston Birth Cohort. I would like to share some background information on Mediterranean-style diet, which is MSD. So MSD typically includes plenty of fruits, vegetables, grains, nuts, and seeds, and olive oil is a primary fat source in this diet. Dairy products, eggs, fish, and poultry in low to moderate amounts. And in the pyramid on the right, we can see that MSD includes multiple nutrients, such as dietary fiber, carbohydrates, vitamins, proteins, and fatty acids, etc. MSD is also found to have extensive health benefits. Studies showed that MSD was associated with lower risk of cardiovascular disease, cancer, cognitive decline, and diabetes. And also, maternal higher adherence to MSD was linked to the reduced risk of adverse pregnancy outcomes. However, the underlying mechanisms are still unclear. Here, I would like to highlight that in the Boston Birth Cohort, I did a previous investigation and found that higher maternal adherence to MSD was associated with lower risk of neurodevelopmental disabilities in the offspring, which indicated the intergenerational influence of MSD. So built on this study, I continued my research in my master's thesis to explore the potential mechanisms. MyCesis aimed to identify postpartum plasma metabolites associated with maternal adherence to MSD during pregnancy, and to further test whether identified metabolites may vary by maternal characteristics, such as overweight, obesity, race, ethnicity, etc. I analyzed 1,410 mothers within the Boston Birth Cohort. The food frequency questionnaires were used to calculate the Mediterranean-style diet score, which is MSDS, during pregnancy. The maternal blood plasma was collected from 24 to 72 hours after delivery. An untargeted metabolomic profiling was conducted at the Broad Institute of MIT. A total of 380 metabolites were analyzed in this study. For the covariates, maternal epidemiological factors were collected from a maternal questionnaire interview, such as maternal age, maternal race, ethnicity, educational level, parity, marital status, etc. And clinical factors, including diabetes, hypertensive disorder of pregnancy, were collected from electronic medical records. In the main analysis, I did descriptive statistics to compare the covariates across tertiles of MSDS. I also did multivariate linear regression models with each postpartum metabolite as Y and continuous MSDS as X. Subgroup and sensitivity analysis was also conducted in my analysis. For example, I did analysis stratified by maternal characteristics, and also used the MSDS tertiles as X and each metabolite as Y in the multivariate linear regression models. It's worth noting that I used the Benjamini-Hochberg method to correct the multiple comparisons in my analysis. The false discovery rate, which is FDR less than 0.05, is considered statistically significant. Now we can see the results. So here is a volcano plot. The x-axis represents the beta coefficients of all 380 metabolites. The y-axis represents the negative log transformed adjusted p-values. And we can see different colors here too. The red represents metabolites positively associated with MSDS. Green represents metabolites negatively associated with the MSDS. And gray represents non-significant metabolites. And let's have a closer look at the identified metabolites. So in summary, 24 out of 380 metabolites were associated with MSDS in this study. And among these 24 metabolites, 21 had positive associations, mainly including lipids. And here we can see the abbreviations of different types of lipids here, such as TAG, PC, PS, and PE, etc. And 3 had negative associations, including 1 amino acid, 1 tryptophan, and 1 nucleotide. So what's the meaning of the findings here? We noticed that 19 out of 24 identified metabolites are lipids, and they were all positively associated with MSDS. Previous studies found that most of the 19 lipids belong to the long chain and highly unsaturated TAGs and PCs. And previous studies found that those types of lipids mainly come from consuming fish, nuts, and vegetable oils, which align with the characteristics of Mediterranean-style diet. Some studies also link the lipids to health outcomes and found that lipids with a higher carbon number and double bond content were associated with a lower risk of type 2 diabetes. This evidence may support the health benefits of MSD. Vitamin A was also found positively associated with MSDS in this study. Vitamin A plays an important role in antioxidant capacity. And studies found that people with a high MSDS were more likely to have an adequate vitamin A intake, which is also consistent with the findings in this study. Adequate vitamin A status was also associated with a lower risk of cardiovascular and cognitive disease, which may also support the health benefits of MSD. Two novel metabolites were also identified in this study. First of all, adenosine was found negatively associated with MSDS. Adenosine was also often considered an inflammation biomarker, and the levels would increase in response to inflammation in obese pregnant women. And adenosine is more likely to be present in individuals with or at risk for preeclampsia and gestational diabetes. Because in this study, we found that people with a high MSDS were more likely to have lower adenosine levels, which may also support the potential health benefits of MSD. The other novel metabolite identified in this study is norcytropine, which is negatively associated with MSDS. However, there is limited research on this association and the metabolite. So more future research is needed to confirm the novel metabolites identified in this study. So in conclusion, 24 metabolites, mainly lipids, in early postpartum were associated with maternal adherence to MSD during pregnancy. Two novel metabolites were identified, which require confirmation in future studies. And this thesis also indicated the critical role of maternal diet in influencing postpartum metabolomic profiles. And future research is warranted to explore the metabolomic changes throughout the pregnancy and postpartum periods, and link identified metabolites to health outcomes to better understand the pathways so that the tailored dietary guidance can be implemented in pregnancy to enhance both maternal and child health in the long term. Because of the time limitation, I didn't put all the findings in today's presentation, but this study was already published in the Journal of Nutrition. If you are interested and want to see more details, please don't hesitate to search and read it online. Last but not least, I would like to thank my readers, Dr. Xiaobing Wang and Dr. Susan Gross, for their invaluable support and guidance throughout the process. I also deeply appreciate Dr. Guo Ying, Dr. Xiu Mei, and Serena for their support in data management and preparation. So any questions or comments? Thank you for listening.
Great presentation, Xiaoyu. I see that CU has her hand up, so go ahead, Xiaoyu.
Hi, Xiaoyu, excellent presentation. I really like your figures and enjoy your insightful discussion. I noticed that in your results, 19 of 24 identified metabolites are lipids. I'm wondering the original proportion of lipids among all metabolites in your study.
Like you want to know the proportion of lipids in the 380 metabolites, like included in my study?
Yeah.
Okay. That's actually a great point because that's one of the comments that I received from the reviewer when I submitted it to the journal. Because it's not only important to know the numbers, but the denominator is always important to know. And actually, I made a table to present all the 380 metabolites in the published version. And if you are interested, I can send that article to you for your convenience. But to answer your question, I think the proportion of lipids in my overall metabolites should be over 50%. Yeah. Thank you for asking.
Thank you for your clarification. I have another question about your results. I noticed that you have done subgroup analysis by maternal characteristics. Can you share something about your subgroup analysis?
Oh, sure. Oh, thank you. Thank you for raising this question. Yeah, I mentioned that in my objective, I would like to identify the metabolites and also to test whether the metabolites may vary by maternal characteristics. And for the method part, the subgroup and sensitivity analysis aligns with the second objective. But I just didn't put the results in my slides today because of the time limitation. And you can see the detailed figure and tables representing the subgroup and sensitivity analysis. But to be more specific, I repeated the multivariate linear regression models in my subgroup and sensitivity analysis. But instead of doing my analysis in the overall sample, I did them in different subgroups. Actually, I used 3 maternal factors to stratify the analysis, including the maternal race, ethnicity, and maternal hypertensive disorder of pregnancy, and also maternal overweight obesity. And I just wanted to see if the results would be different among the subgroups. And I also added an interaction term into the multivariate linear regression model to test for the potential effect modification. Yeah, and thank you for asking.
Thank you. I really enjoy your discussion. Thank you.
We have one question in the comments from David Page. He would like you to comment on data on pregnancy outcome regarding the pregnancy and the newborn related to this.
Oh, if it refers to this master thesis, I would say I didn't include the health outcomes in this thesis. I just did an exploration, like what kind of metabolites were associated with the maternal adherence to MSD. But we do have this kind of outcomes in the Boston Birth Cohort dataset. But so the future studies is needed to link the identified metabolites to the pregnancy outcomes. Yeah.
Yes. Thank you. Thank you very much. A wonderful presentation.
Thank you.
And wonderful team.
Kristen, do we have time for more questions?
No, we have to go on to the next.
Okay. Thank you, Xiaoyu.
Thank you.
For the presentation. So our next speaker is Gabrielle Vergerio. She comes to us from Brown University with a Bachelor of Arts in Public Health. Her area of interest is child health, and her master's essay is The Vegan Diet During Pregnancy and the Implications for Fetal Growth and Development, a Scoping Review.
Hi, everyone. Thank you, Dr. Gross, for the introduction. So I'm Gabby Vergerio, and I am very excited to present my findings with you today. First off, I want to give some special thanks to, of course, Dr. Gross, who not only served as my academic advisor throughout my master's program, but also as my primary reader. I would also like to thank Lori Rossman, who's an amazing informationist, helped me to develop my search strategies for this scoping review, the Population, Family, and Reproductive Health Department, my family, my fiance, my friends, and my sweet dog, Frankie, that is pictured here. So just a brief overview of what I'll be discussing today. I'll go over some quick background information relevant to the scoping review. I'll go over my methodologies, my results, and then a brief discussion and conclusion section. Starting off with background, you may be wondering why this topic is important to me. So personally, I've been vegan for almost 6 years now, and being a part of this program, you really learn a lot about the importance of periconceptional nutrition and the relationship that is clear between the maternal diet, fetal development, and long-term health outcomes for both the mother and the child, and then also with my personal goal of starting a family one day. The objective of this scoping review was to explore the safety and appropriateness of vegan diets during this critical period of pregnancy for proper fetal growth and development, especially with the rise of veganism seen in high-income countries and within the age bracket of women of reproductive age. So now some background on the maternal diet and veganism. So as I mentioned before, the maternal diet has clear linkages between what the woman is consuming and the outcomes of both the mother and the child. And it matters most during this periconception period, which is the 14 weeks before pregnancy up to 10 weeks post-conception. And now some background on the vegan diet, just to differentiate it from other plant-based diets. So it's unique in its exclusion of all animal-derived products, including meat, fish, eggs, honey, dairy. And there are lots of benefits and motivations that lead people to be a part of this diet, including health benefits, environmental benefits, as well as ethical beliefs. There are key deficiencies associated with the vegan diet, most notably vitamin B12. We do see societal and political shifts pushing towards more plant-based eating. We can see national dietary guidelines encouraging plant-based eating for all age brackets, including women who are pregnant. We see increased rates of veganism in high-income countries and, like I mentioned, reproductive age women. And there is a limited amount of literature on this topic. Onto my methodologies. So I did conduct a scoping review on this topic. The databases that I used were PubMed and Psychosocial. And here you can see my inclusion and exclusion criteria listed out. But basically the studies included in my scoping review were all peer-reviewed, published in English, published in recent dates, so 2010 onwards. And they all discuss plant-based diets during the life course in some capacity. Here are my search methods for both PubMed and Psychosocial. And then here's just a quick visual just to help you see the screening process that I went through, starting off with around 1,100 total articles included in both PubMed and Psychosocial, and then I ended up with a total of 39 studies that were included in this review. And then also just a quick visual of the summarization process that I went through. Of course, you're not meant to see all of the little details, but just to see that this was actually my condensed version of my summary table. So there was a lot of organization and going through all of the studies to find all of the details. Here's a breakdown of my primary source methods. So the vast majority were cross-sectional surveys, closely followed by prospective cohort studies, but there were a range of other methodologies used in the studies. Here's a visual of the publications on this topic by year. So we see from 2012 to 2021, a gradual increase in the literature on maternal vegan diets, which makes sense with the popularity of veganism increasing in high-income countries and in women of reproductive age. But we actually see a drop-off from 2021 to 2023, which is interesting and also potentially concerning. Here's a regional breakdown of the primary papers. So the majority of the papers were from the European region, but we also have others from North America, Asia, and Australia. And onto the results. So I categorized my results into 3 main categories listed here, and you can also see the number of studies that contributed to each category. I'm going to start off with the maternal vegan diet with its micronutrient intakes and nutrient levels. As I noted here, there were conflicting results. So some studies showed that women following maternal vegan diets had healthy levels of micronutrients and especially high in folate and vitamin K. But then we also saw some potentially concerning results from other studies that there were noticeable deficiencies in key micronutrients, including B12, B2, D, and iodine. And then another study showed that there was no significant association between micronutrient levels and outcomes such as gestational age and birth weight. The next category of results was macronutrient intake and health outcomes for women following vegan diets. Again, also conflicting results. So some studies showed positive outcomes such as reduced risks of inappropriate gestational weight gain, gestational diabetes, and large for gestational age births. But then others showed some negative outcomes such as higher risks of lower birth weights and small for gestational age births. Other studies showed that there was no association between macronutrient intake with maternal weights, gestational weight gain, gestational diabetes, BMIs for both the mother and the infant, birth weights and lengths, and preterm births. And I want you to especially notice the fact that this scoping review was not able to confirm a relationship between macronutrient intakes and preterm births, which is contrary to previous literature. Another result was that there was an overall lack of protein seen in maternal diets, not just for women following vegan diets, but overall. And there were different health outcomes between women from different cultures following a maternal vegan diet, which is very interesting. The last category of results was on healthcare professional knowledge of the maternal vegan diet. So these results were all, they were all finding the same thing. So there was an overall lack of reported healthcare knowledge on maternal vegan diets, including very basic things such as definitions, benefits of vegan diets, as well as risks. There were also insufficient current healthcare practices involving diet. So a lot of healthcare professionals noted not even bringing up maternal diet in the first couple of appointments, which is concerning. And then positively, we saw high levels of interest in learning more about the maternal vegan diet from healthcare professionals. Now on to a brief discussion and conclusion section. So here I just listed out what's consistent between my scoping review and previous literature, which includes the fact that this scoping review was able to confirm that there is an association between maternal diet, gestational weight gain, gestational diabetes, birth weight, and size for gestational age. What was inconsistent, as I mentioned before, was that this scoping review was not able to confirm an association between the maternal diet and preterm birth. Here are some strengths and limitations. I won't go through all of them, but just some to note are that there were strengths in covering a wide range of high-income countries and including current literature, but there were not able to be studies on low and middle income countries, which would be interesting for further research. And there is potential for bias, and this study is not able to consider other factors such as postpartum experience. So implications and future recommendations. As I mentioned before, more research in this area is definitely needed, especially across low and middle income countries. Standardized global nutrition guidelines would be extremely helpful for minimizing confusion for both healthcare practitioners as well as patients. Medical training should be adapted to train professionals more on caring for women following vegan diets. And for women who are choosing to be on vegan diets, it's emphasized that they should follow well-rounded diets with proper supplementation, as well as utilizing dietary counseling when available and monitoring fetal growth throughout the pregnancy. And then here are my references. Thank you. Any questions?
Thank you, Gabby. Great presentation. Do we have any questions? Okay, Stacy has a question.
Hi, thanks for this presentation. I was just wondering that when you were summarizing the literature, did you notice any commonalities or anything surprising regarding like demographic characteristics or any other descriptors about the sample in the articles that you included in your literature review?
Yeah, thank you for the question. So as I mentioned, the literature on this topic is pretty limited. So there was a wide range of populations covered, and there wasn't a lot of consistencies a lot of the time, which could lead to limitations in the generalizability of the study. But in terms of limitations as well, there were really no studies on low and middle income countries. I think throughout my screening process, I was only able to find one in Iran. And so that really shows that there is a lack of literature available for those populations and definitely necessary for future research.
Emily, do you want to say your comment or?
Sure. Great job. I was just thinking that I know in scoping reviews, you often don't have time to evaluate the quality of the evidence, but I was just thinking, if a future systematic review were to look at this topic, it'd be interesting to look at potential risk of bias or how well the studies have been conducted in this area. So great work.
Thank you so much.
Kristen, how are we doing on time?
Yeah, we can go, if there's no more questions, we can go on to the next student.
All right. Thank you so much, Gabby. That was a great presentation. Our next presenter is Anna Levashkevich. She comes to us from University of Michigan. She has a Bachelor of Arts in International Studies and Economics. She was part of the area of interest of women's sexual reproductive health, and her master's essay title is The Evolution and Analysis of the U.S. Food and Drug Administration's Regulation of Mifepristone through Risk Evaluation and Mitigation Strategy Program.
Thank you. Quite a title, I know. So we're going to try to cover some things relatively quickly. Some of the things we'll be covering include a research overview, the FDA regulatory overview and the focus of our analysis, a Mifepristone timeline overview, some of the changes that have occurred in the REMS regulation, which we'll be talking about, and then some rationale from the FDA for the enforcement of the REMS and just some concluding thoughts. So just for some context, Mifepristone in combination with misoprostol is the most widely used abortion regimen in the US. It comprised over 63% of abortions in 2023 in the country. The FDA has always restricted the distribution of Mifepristone since its approval in 2000, first through something known as the Subpart H restricted distribution program, and then through a risk evaluation and mitigation strategy REMS program. For the purpose of our talk today, you can think of these two things as essentially the same policy. For a long time, medical organizations such as the American College of Obstetrics and Gynecology, the American Medical Association, and the American Academy of Family Physicians have always advocated for the removal of the REMS for Mifepristone, as they do not believe it to be clinically necessary. There's really relatively little transparency around the Mifepristone REMS program from the FDA. So as part of ongoing work, Dr. Caleb Alexander submitted a Freedom of Information Act, a FOIA request to the FDA for internal documents regarding the regulation of Mifepristone. So some of our methods, we evaluated over 5,000 pages of FOIA documents in addition to Mifepristone archives, searches through public health journals, and external policy briefs. And the goal of the analysis is to evaluate the FDA's regulation of the Mifepristone REMS and to bring public attention to this issue. We conclude in our findings that the FDA has acted in a rational manner as a regulator. We didn't find any evidence of misconduct regarding the approval or revision of the regulation of the drug. However, we do find that the analysis that has been provided has been really, really limited. And the REMS really has some really serious kind of implications to the distribution of Mifepristone. And we believe that they need to kind of publicly provide more rationale if they want to continue enforcing this regulation, specifically the elements to assure safe use, the TASU, which we'll talk more about in the later aspects of the presentation. And the implication of a REMS with a TASU for this drug is that this drug could not be safely used without these restrictions, and it would otherwise not be approved without the restrictions, which, as we've discussed, I think most medical organizations take issue with that statement. So just to kind of orient us in terms of where our review occurred, we were mostly focused on the FDA review and post-approval marketing phases of the drug development pathway. That's where the REMS and the Subpart H approval really comes into play. We didn't really focus on other aspects of the drug development path or other aspects of FDA kind of regulation, like the label and other things. In terms of some of the relevant elements within the REMS for Mifepristone, again, we want to emphasize that this REMS enforces a TASU, or elements to assure safe use, and that it means that the drug cannot be safely used and wouldn't have been approved without these elements. So in order to enforce this, the FDA must consider additional factors such as that the Itasu are commensurate to a specific risk on the label of the drug. For Mifepristone, this risk is a risk of serious infection, and the Itasu do not unduly burden patient access. And you'll see a list of the types of Itasu that have been historically applied to Mifepristone. So again, generally, the Subpart H REMS programs are used when there is a need for additional restrictions to assure safe use of a drug. And generally, they've been used to apply to drugs that treat really serious conditions and provide meaningful therapeutic benefits over existing treatments. One benefit of these programs is that it gives the FDA authority for structured follow-through, dispute resolution, and enforcement with the pharmaceutical manufacturer. Although, again, this can't be the basis of requiring the REMS program. We also created the timeline of the Mifepristone overview and regulatory history. I unfortunately don't have time to go into every single event here, but I just wanted to highlight that the approval process for Mifepristone really took a long time. There were difficulties securing a manufacturer for the drug, and the studies were actually undertaken by a research organization as opposed to a pharmaceutical company, so it's fairly different. And that was partially because of the really difficult abortion environment that we have in the United States. And then Mifepristone was approved with a restricted distribution system in 2000. And, originally it was approved in France in 1988. And I want to just highlight a couple of recent things that have really started occurring since the pandemic. There's been multiple lawsuits over how the FDA was applying the REMS program even during the COVID pandemic. The REMS program has an in-person dispensation requirement. And so ACOG actually sued the FDA to prevent them from enforcing this. And then there was another suit, the Chalias v. Becerra suit, after which the FDA agreed to reevaluate the REMS program, specifically in consideration of the in-person dispensation requirement. And most recently, the Supreme Court has heard arguments on a case that touches some of these revisions to the REMS. There's been three main versions of the REMS, the 2011 version, 2016, and 2023. Some aspects have really remained the same, and then some aspects are now different. The main thing that has really not changed over the years is the fact that prescribers have to complete a prescriber agreement. And in this agreement, they agree that they meet the following qualifications. So they have the ability to assess the duration of a pregnancy, ability to diagnose ectopic pregnancy, and ability to provide surgical intervention in case of incomplete abortion or refer out for such care. There's been no changes to this requirement. And then the one that has changed most recently was the in-person dispensation requirement. So the FDA reviewed it and they removed it in 2023 because they now had data showing that this requirement did not lead to increased safe use of the drug, but instead they add a pharmaceutical certification requirement, which is a TASU-B. So we also considered some of the rationale that we found in our document review for why these systems have kind of always been in place for this drug. So starting in Subpart H, which is the system that it was approved under in 2000, in order to approve a drug under Subpart H, the FDA had to conclude that the drug treated a serious condition. So they determined that a termination of a pregnancy is a serious condition, and that the avoidance of a physical abortion was a meaningful therapeutic benefit and an avoidance of a procedure. And the agency felt that Subpart H would give it the ability to enforce an agreed upon distribution system. There was always going to be a distribution in place for the drug at the beginning of the approval. Both the manufacturer and the FDA agreed on this. They believed that only qualified providers should be administering the drug, and the drug was only shown to be effective under certain conditions and trials. So we then reviewed a 2013 REMS review and a 2021 REMS review. I would say that both are characterized by the fact that there's really limited evidence for maintaining these ITASU components. And there's no real evidence on the implication to real healthcare outcomes for women. And so a lot of the times the FDA kind of relies on other aspects such as monitoring, distribution, and confidentiality, which again don't really tie back to the risks mentioned on the label for mifepristone. And then, they really focus in the 2021 review on this in-person dispensation requirement. And they kind of conclude that they now have enough evidence that the lack of in-person dispensation does not lead to increased risk of use of mifepristone, but they were really only able to get that evidence because of the threat of litigation and because of lawsuits that prohibited them from enforcing it. And so it's not really clear if sufficient evidence could have been generated without a court order enjoining the enforcement of ITAS-2B, and if they would have reconsidered it without subsequent litigation. So just some concluding thoughts. We do believe that the FDA has really taken steps to make mifepristone, the REMS, more transparent, but it's difficult to understand the overall rationale for maintaining the REMS, even after looking through thousands and thousands of documents. And the evaluations for the REMS as a whole are inconsistent, reactionary, and they seem to be based on analysis outside of the actual health outcomes of the mifepristone REMS. We do still think that the FDA acts as a rational policymaking body. We have a really hostile abortion environment in the US. It makes sense that the FDA might want to have additional information about the manufacturing of the drug and the distribution of it, but that's not sufficient to meet the terms of the statute under which the FDA may enforce a REMS with the TASU. So we really just advocate for more publication of internal FDA rationale behind the enforcement of this drug or the enforcement of the REMS for this drug. And we just currently believe that the information we have seen doesn't meet the burden of proof implied by the seriousness of the statute that governs this drug. I also have some impacts mentioned on the slide, but I wanted to just yield some time to questions.
All right. So it sounds like Anna wants questions now. So does anyone have any questions? And I want to say this is such a complex system that you described for us today. It's really mind-boggling how much goes into just this one part of things. I mean, this is just about the REMS, but I guess my question.
Oh, go ahead.
My question is what would the next we have the court cases, would they force another review, do you think, or what would be the next thing you could see happening?
Yeah, so it really depends on the outcome of the Supreme Court case. I think it's unlikely that it would force another review at this point. Also, based off of listening to the case, I think it's unlikely that they're going to force the FDA to go back to in-person dispensation. They might not find merits for the case. But, based off of the way things have currently gone, I think in order for the FDA to reconsider some of those other aspects of the REMS that remain in place, more lawsuits would have to be brought by interested parties, specifically addressing each ITASU. The problem is it's really difficult to generate evidence on these things. Like if you have to administer the drug by these rules, I don't know how you generate evidence with its use kind of outside of that. But there are people looking to generate evidence for self-managed abortion that is kind of entirely outside of the system. And so maybe if we have better evidence around that, that could be convincing to the FDA. But I do know that they reviewed some of like the aid access data and I think did not find it to be sufficient for removing like the last remaining components. And in fact, they had another restriction in the most recent review. But yes, very complex program, and it was difficult to think about how to introduce this in such a short period of time.
You did a great job.
Thank you.
Any questions? Any other questions? Kristen, how are we doing on time?
We can go to the next student, the last student. Yes.
Okay. Thank you so much, Anna. So our last speaker, but not least, is Ayumi Uchiyama. She comes to us from Tokyo University of Foreign Studies with a Bachelor of Arts in International Studies. Her concentration was women's sexual reproductive health, and her essay topic is population level estimates of equitable gender norms, results of mobile phone health survey panels in Bangladesh, Colombia, and Uganda.
All right, thank you so much for the introduction. Hello, everyone. My name is Ayumi, and today I'll be presenting on population level estimates of equitable gender norms using the data from mobile phone health survey panels conducted in Bangladesh, Colombia, and Uganda. So let's start by looking at health through a gender lens and thinking about how gender norms impact health throughout a life course. Individuals are living in a gender system where norms are produced and enforced in family, community, institutions, and policies. And this gender system of norms also interacts with other social determinants of health, such as race and class, and creates gendered pathway to health. Restrictive gender norms can lead to gender differences in exposure, access to care, harmful health behaviors, discriminative health system responses, and even biased data collection and research. And this is why addressing restrictive gender norms is key to driving health equity. So previous studies have shown the important linkage between gender norms and health, but then how do we measure the current state and change in gender norms? Most studies on gender norms have used qualitative methods. There is a lack of direct quantifiable indicators of gender norms measured with a valid and reliable survey instrument. Gender Equitable Men Scale is one of the few existing measures of gender norms. And this scale was originally developed in Brazil and used in program evaluation of interventions promoting equitable norms to prevent HIV, STI, and intimate partner violence. The previous use of this scale, however, was limited to a specific location and population, such as male youth in urban cities. And without nationally representative samples, findings are not generalizable or scalable to other settings. And lastly, previous data collection using this scale took face-to-face interviews, which are really resource intensive. With an increasing mobile coverage in low and middle income countries, mobile phone surveys present a unique opportunity to conduct a cost-effective, large-scale survey study. So the aim of my study was to estimate the prevalence of equitable gender norms in Bangladesh, Colombia, and Uganda using data from mobile phone surveys adapted from the GEM scale. This survey was conducted in 2023 among adults in those three countries. This was a panel survey, so participants received a set of questionnaire in 3 waves every 2 weeks. And each wave contained a unique set of gender norm questions. The random digit dialing method was used to collect nationally representative samples for each country. The survey also used interactive voice response, where respondents listened to pre-recorded messages and selected responses with the keypad on their phone. And finally, the gender norm questionnaire was adapted from the Gender Equitable Men Scale. Colombia and Uganda questionnaires included 22 items, and Bangladesh had 27 items. Those questions were asked either in equitable or inequitable note. So equitable statements are those that are supportive of gender equity, such as a couple should decide together if they want to have children. And on the other hand, inequitable statements conform existing stereotypes, harmful beliefs, and discriminatory behaviors based on gender, such as there are times women deserve to be beaten. And respondents answered to each question by selecting agree, partially agree, disagree, refuse, or hang up. Lastly, items covered 5 thematic areas, including gender roles and stereotypes, decision-making, violence and control, sexuality, and societal value. The first step of my analysis was to describe participants' characteristics and responses to each gender norm question. Then I used regression analysis to explore the relationship between those characteristics and gender norms. Then I created an outcome variable, which was defined as the prevalence of equitable gender norms. The detailed process is shown on the right side of the slide. I first dichotomized responses to each gender norm item. I coded the worst performing group as 0 and the rest as 1. Then I created an additive score of all responses. So here, a higher score represents more equity in norms. And to fit into a multinomial regression model, the final outcome variable was treated as categorical by dividing the additive score into 3 equal sized groups of inequitable, fairly equitable, and equitable norms. Covariates were age groups, sex, location, and education. In weighted analysis, rake weighting was used to make the survey representative of the underlying population distribution. The results of my descriptive analysis show that the level of equity in gender norms varied by countries, directions of questions, and domains. However, generally, Colombia had the most equitable norms across 5 thematic areas. Bangladesh performed better compared to Uganda, except in the sexuality domain. So the figures on the slide show weighted responses to those two questions. Question 15 on the left asked about acceptance of violence against women. So we see that the proportion of worst performing group is the smallest in Colombia and largest in Uganda. But on the other hand, question 27 regarding sexual activity shows a different pattern. The majority of respondents in Bangladesh agreed that women should be virgins before marriage, while the proportions were much smaller in Uganda and Colombia. And this was likely due to the sensitive nature of these questions. This table shows the results of adjusted and weighted multinomial regression analysis. The most inequitable category served as a base outcome, and the odds of having fairly equitable and most equitable norms are reported here. Overall, each country had a unique set of predictors of equitable norms. In Bangladesh, women were more likely to have equitable norms compared to men, but sex had no associations with norms in Colombia and Uganda. The relationship between age and norms was generally weak in all countries. Location had mixed effects. In Uganda, urban residents tended to show more equitable attitudes than rural populations, while it was the opposite in Colombia. Lastly, education emerged as a strong predictor of equitable attitudes across countries. Participants with secondary education and above were more likely to have equitable norms compared to those who had no education or primary education at most. This study has some strengths and limitations. To my knowledge, this is the first study to employ the gender equitable Mint scale in mobile phone surveys to capture gender norms in multiple LMICs with nationally representative samples. The gender norm questionnaire had cross-cutting themes beyond sexual and reproductive health, which many gender and health studies had previously focused on. Although I was not able to include this in my previous slides, the questionnaire actively used symmetrical questions that contrasted expectation towards men and women and girls and boys, instead of asking only about women's role as a caregiver, for example. One of the key limitations of the study was insufficient sample size in older female groups, potentially due to their barriers to accessing mobile phones. Secondly, our survey did not include explicit questions on gender identity in order to make the questionnaire culturally appropriate. Lastly, the survey did not collect some key sociodemographic indicators related to gender norms, namely income, employment, and mother's education. A comprehensive set of characteristics will help explore their associations with gender norms in greater detail. In conclusion, this study contributes to survey research investigating relationship between gender norms and health outcomes beyond sexual and reproductive health. Future research should combine this gender norm questionnaire and qualitative methods to understand how gender norms influence health and create differential impacts by geographical or cultural context. And I cannot stress enough the importance of intersectional theory, and gender transformative approaches. So while managing cultural considerations, survey instruments should be inclusive of diverse identities as well as the environments people live in, so that health research does not reinforce or replicate existing gender biases, as we've seen in the very first slide of this presentation. And this will also help us explore how people perceive and experience norms and inequities beyond binary understanding of gender. This is the end of my presentation. I want to thank my advisors from Data for Health Initiative, Professor Seifedin, Dr. Zesti, and Dr. Kibria. I also want to thank Hofan faculty and friends and my family. All the learnings and accomplishments I made in these 2 years were because of the support and encouragement I received from all of these people. Thank you so much, and please share if you have any questions.
Thank you, Ayumi. That was a great presentation. Are there any questions? Xiaoyu.
Yeah. Hi, Ayumi. Great presentation. And I really like the visualization you did. Like in the second slide, you present the framework you made to show how the gender norms would impact the health. And I'm just wondering, like, about, can you go back to the implication slide? Yeah. And yeah, sure. Yeah, thank you. So I'm just wondering, like, what you mean by incorporating the intersectional theory and gender transformative approaches, because I'm not that familiar about this topic. Yeah, but I think this topic is very interesting. Yeah, can you share a little bit more?
Yeah, thank you so much for that. So what I mean by here, for example, intersectionality, as I share in the first slide, you know, gender is connected to other social determinants of health. So survey studies like this should consider gender in relation to other factors, for example, income, location, education, employment, you know. So I think stratification and subgroup analysis will be a key. And that way, I think we'll be able to better understand how differently those inequitable norms or gender inequality manifest in those subgroups. And for gender transformative approaches, what I mean by this is that's the survey question or instrument avoid replicating existing stereotypes. Like, for example, is your survey only asking about women's role as a caregiver or men's role as a decision maker? Or are you asking to both populations from both perspectives? So I think that way, those gender transformative research, you know, not only contributes to capturing norms and inequities, those blurry concepts, but also contributes to social change and advancing equity through the power of research.
Thank you. Thank you so much for clarification. Great job.
Thank you.
All right. Stacy has a question.
Yes, thank you. I actually have 2 questions. But before that, I don't know if you're connected with Sam Beckwith already, but this topic's really similar to what he did for his dissertation, so connect with him. So my first question is if there are any, like if you can talk a little bit about the cultural differences in how equity is interpreted, or if there are any differences in how equity is interpreted within each of these countries. And then my related second question is, like each of these countries isn't a monolith. And so are there any variations within the countries about how equity could be interpreted?
Yeah, thank you so much. That's a great question. And that's something I need to work on to make this capstone into publication. I did not have time to go into each country and then understand, you know, contextual factors like culture, religion, education level, and things like that. But I'm definitely going to work on that in the next step of my project, and I'll keep that in mind. But I know that there's a variety of those factors between each country, but also within those countries. So I'm definitely going to take notes of your question and work on that. Thank you so much for raising that point.
Any other questions? Well, I want to say thank you to Ayumi, but thank you to all of our panelists. They did an excellent job today, and thank you to everyone who came today. We will have next Wednesday another wonderful panel of population, family, and reproductive health master's essay presentations, and I hope everyone comes back to join that.